Okay, good afternoon, everyone. Welcome to the second lunch session for the WHO's Health for All Film Festival. Today's theme is going to be sexual and reproductive health and rights. I want to give a little note here before we start, just so you all know. There is no graphic content in the three films that we'll be screening today, but they will be addressing the themes of female genital cutting. They will also be addressing themes of migration, forced migration due to violence, and about fetal loss. I just want to share that with all of you. They're also films with positive messages, but I think it's important to say beforehand that you know what to expect in the three films you'll be seeing today. So we have some wonderful, illustrious, exciting speakers to join us today. Koiwah Koi-Larbi is joining us here on the stage. Hello. She is the founder of Action on Preeclampsia Ghana, and will be telling us more about her projects and her involvement with preeclampsia efforts. Online, we have two speakers joining us today. Hello. So our first speaker is Dr. Christina Pallitto, who is the WHO Department of Sexual and Reproductive Health and Research Technical Lead on Female Genital Mutilation. Hi, Christina. See if she could wave to us. And Dr. Doris Chou is online as well. She's a medical officer working for the WHO Department of Sexual and Reproductive Health and Research in the Department of Maternal and Perinatal Health. Hello, Doris. Great, and as always, Gilles Reboux is joining us today, and Gilles is the film festival leader and founder, and he'll tell us a little bit more about the film festival.
Thank you, thanks a lot, Megan. And I thank you again, I said that, but we have new people, and Joyce Brown as well, for inviting us in this conference to have these special sessions on the film festival by the WHO. That's really great to have this opportunity.
Great.
So I will, hello everybody, good afternoon. I don't know if some of you were here already yesterday. Do you have, no? We have new, okay. So I will repeat something that you heard yesterday about the concept of the Health for All Film Festival. So Health for All, as for me, is really a multi-sectoral concern. We saw that during the pandemic and COVID, that transportation were affected, then the workplace, the business were affected, the schools, the education were affected, and so on and so on. And of course, these are consequences of a pandemic, but the causes also, when we look at causes of many health issues, we can see that multi-sectoral concern is often very important. The concept of this Health for All Film Festival is something I designed in 2019 and proposed to Dr. Tedros, the WHO Director General. And after the first edition, which was in 2020, we have received 1,300 short films from 110 countries. So Dr. Tedros decided that we should, in the WHO, sustain this initiative on a yearly basis. So films are a powerful way to raise awareness, improve understanding, and encourage positive behavior change. So that's the philosophy and why we want to encourage champions of health to submit their films. It's open to NGOs, to students, to public institutions. An important thing to remember is that the United Nations production, the films by different UN agencies are not eligible, because we really want to call for people outside the UN system to tell their stories on health. So let's share, for instance, now we have a call for films. The 5th call for films is running at the moment. It was open on 1st November, and it's going to close on 31 January 24. And every year we have 3 main categories, as you can see on the screen: universal health coverage, health emergencies, and better health and well-being. And in fact, these 3 main categories, decided by Dr. Tedros for the festival, are the main global health public health goal that the WHO is promoting in its general program of work currently operating. And every year we have a special focus on 2 themes. So in 23 we had climate change and health, and sexual and reproductive health. And that's why we have this session today on SRHR. And as you noticed, maybe in the logos that my 2 colleagues had behind themselves, you saw HRP, the Human Reproductive Health Program. It was the 50th anniversary of HRP program this year, so that's why we had also this special focus on this topic. And for next year, if you want to submit a film and or you know people who could submit, you could spread the word, thank you very much. You have Physical Activity and Health as a special film prize, and Migrants and Refugees Health also as a special film prize. One big important goal is that we want to promote films for health impact and how a film can really bring behavior change for better health. So we have a special, I invite you to visit the web page. We have a special page dedicated to that, and several educational tools are already placed there, and as well related links to different activities that WHO is developing in this context, like behavioral science for better health. We have the World Health Assembly in 23 has adopted that behavioral insights should be part of all health systems activities, and WHO, of course, has developed a unit for that, and in order to help the governments to develop more behavioral insights in their activities and implementation of health care and so on. So you can visit this webpage and know more about that. Now, the 3 films we are going to see today are not necessarily the ones selected in 23 SRHR category. They are winning films from also previous editions, like this one, Efun, about FGM, female genital mutilation in Nigeria. Was the winner in 21 of Health Education Special Film Prize. We have preeclampsia, predict earlier, prevent earlier, that you're going to see, which was the Grand Prix winner in 22 of a universal health coverage category. And we are going to see another winner from 2020 edition. There was a category, a special category at that time on nurses and midwives, because it was the year of the nurse and the midwife in 2020. So you will see this film, War and Grace, about training midwifery in a war situation. So situation which could resonate to other wars that we are seeing at the moment. And if you want to look at the full list of films selected in the sexual and reproductive health category this year, you can go to our website. You will see official selection button, and you will go to the list. And we have also YouTube playlists where you can see the films from the festival. So I think I'm done. Yeah. I'm in time? Yeah. Okay. Let's watch the films.
Screen those films. Enjoy.
EA says every girl must pass through this rite to become a woman. It is tradition, and girls who go through it are clean, beautiful, and become real women.
It is time.
Can I play with them just once more?
No, you are no longer like them. Today, you become a woman.
I don't want to do this.
You don't have a choice. Don't worry, you won't see it.
The last time EA prepared someone for this rite, it was my sister, Osayi. I remember Osayi telling me what it is like. She said it is like a journey to hell and back, even though none of us has been there before. A part of her was cut away. She never got better. She died. EA said it is God's will.
They'll be here soon. okay? Don't worry, it will be quick.
I don't want to be like Osai. What if I have a choice?
You know, choice isn't one of the luxuries of every woman.
I want to be a woman, but I also want to be able to make choices.
Kehamilan, perjalanan magis serta religius selama 280 hari untuk kehidupan baru yang lebih indah. Kehamilan bukan hanya kebahagiaan sebuah pasangan, tapi juga untuk seluruh keluarga besar mereka. Di saat itulah, kehidupan manusia bermula. Kebanyakan kehamilan berlangsung indah, namun ada juga yang tidak sesuai harapan. Seorang guru kami mengatakan kehamilan itu seperti kondisi saat hujan. Kadang berakhir pelangi, kadang berakhir petir dan badai. Salah satunya adalah preeclampsia. Ini adalah cerita kehamilan kedua Ibu Dian, di mana di kehamilan pertamanya, bayinya meninggal di dalam kandungan saat usia kehamilan 28 minggu akibat ibu ini mengalami preeclampsia.
Tensinya ternyata nggak turun-turun kan, setiap cek nggak turun, sampai akhirnya tambah naik tuh. Sebenarnya awalnya mau cek, ini udah mau trimester 3 kan, ulu hati itu sakit. Terus kita ke klinik, ternyata tensinya udah 160/100 gitu. Langsung dirujuk untuk rawat inap gitu. Nah selama rawat inap itu ternyata makin parah gejalanya, udah pusing, udah mata kunang-kunang seperti itu. Yang gejala khas preeklampsia kita tahu ya, pas sudah selesai itu kan kita langsung cari tahu, oh emang ini ternyata gejalanya.
Preeklampsia adalah kondisi di mana seorang ibu hamil secara tiba-tiba mengalami tekanan darah tinggi pada usia kehamilan di atas 20 minggu yang dapat disertai dengan gangguan fungsi organ lain ibu maupun pada pertumbuhan janinnya. Preeklampsia merupakan salah satu penyumbang angka kematian ibu hamil dan bayi tertinggi di dunia. Sebanyak 76.000 perempuan dan 500.000 bayi meninggal akibat preeklampsia setiap tahunnya.
11-13 minggu itu di USG, terus cek darah juga ya, itu buat screening untuk ngecek berapa besar kemungkinan kejadian preeklampsia ke depannya. Cek aliran darah ke plasenta dari yang di perut itu, USG-nya.
Janinnya efeknya apa? Dia kecil bayinya, ya kan? Terus ya bisa juga sewaktu-waktu dia nggak ada, yang kayak riwayat yang pertama itu, ya kan? Nah ke ibunya seluruh organ, Pak, seluruh organ dia bisa dipengaruhi, mulai dari kepalanya, otaknya, ya kan, pembuluh darahnya. Karena racun ini kan dia beredar di pembuluh darah, jadi dia disirkulasi baik ke ibunya maupun ke janinnya, gitu. Nah makanya ada preeklamsia yang kena ke ginjal, jadilah dia proteinnya bocor di situ, ya kan, di urinnya tuh ketemu protein kan dulu kan kalau preeklamsia. Terus di otaknya bisa suatu saat kejang kayak gitu-gitu. Sampai saat ini sih alhamdulillah semua terkontrol, ya kan, pertumbuhan bayinya oke, ya kan, ibu tekanan darahnya oke. Hasil-hasil lab juga sejauh ini insya Allah baik. Nah mudah-mudahan nih sampai nanti 38 minggu semuanya oke Pak. Bismillah ya Bu, mudah-mudahan lancar ya. Ya ini kita udah berjuang, tinggal kita serahkan sama Allah lah ya. Yang penting kita udah usaha, tinggal hasilnya kan udah ada yang ngatur Pak ya.
Sebenarnya yang paling dikhawatirin itu kalau tensinya naik sih. Nah, sampai sejauh ini sih masih normal-normal terus. Tuh udah lebih tenang sih kalau itu karena udah terpantau.
Sampai saat ini kehamilannya sudah 36 minggu dan alhamdulillah sejauh ini kondisi bayinya dalam kondisi baik, pertumbuhan bayinya baik, ibunya juga dalam kondisi baik, tekanan darahnya terkontrol dan sampai saat ini tidak ada tanda-tanda gangguan di organ-organ ibunya, dan kita akan mempersiapkan untuk persalinannya secara sesar di usia 38 minggu.
Ya harapan saya ya anaknya sehat sih, sama istrinya juga sehat ya, persalinan juga lancar nanti, nggak ada kendala apa-apa sih, itu aja sih.
Pada akhirnya, malaikat kecil yang dinanti menjadi pembawa kebahagiaan untuk keluarga mereka. Meskipun peristiwa yang lalu masih memberikan luka yang teramat dalam, yang tak bisa dilupakan. Banyak ibu hamil yang belum teredukasi mengenai pentingnya screening preeklamsia di awal kehamilan. Walaupun sebenarnya sebagian risiko preeklamsia dapat dideteksi lebih awal sehingga dapat dicegah komplikasinya.
Adiknya udah lahir, alhamdulillah sih seneng banget, luar biasa, udah nggak kebayang lagi bahagianya kayak gimana.
Pas senangnya pas ya dipanggil masuk, pas suruh ini ngajanin anaknya, kayaknya lega aja gitu udah. Nanti yang lama kan.
Ya bayinya juga
Iya, bayinya
sehat.
juga sehat, istrinya saya juga sehat.
Life is a miracle. Life is a battle. Life persists against all odds. In South Sudan, life is defined by war. Generations of children have been born into violence. Millions have been displaced, still searching for home, still waiting for peace. It is the youngest country in the world with the largest humanitarian presence and staggeringly high maternal mortality. Here lies the whole horror and beauty of human existence. It's one of the most difficult and dangerous places to be a woman.
My name's Grace Rocio. I'm a South Sudanese. I was born in Uganda in a refugee camp in 1968. I trained as a nurse. I worked for around 10 years. From there, what motivated me to become a midwife was the mortality rate of mothers and babies in the country. The death rate of mothers in South Sudan was too high. So the initiative of training midwives had to begin. In 2006, they opened a national training school for Kajokeji. Had 3 classrooms, a dormitory for boys, dormitory for girls. We were about 105 students, and then there was problem of insecurity in Kajokeji. There was a lot of gun shootings. The community had all run away. We decided to move away from the school. All what we had were left behind. We only secured lives of people. I had 2 things to decide on. I had a family, which is my biological family, and I had a family which was the students. But I had to sacrifice my life and let the children go with the father to the refugee camp, then made sure that I moved with the students to come to Juba. It comes easy to insert into the vagina. When we arrived in Juba, we rented a place for the students. It's not designed for a school. So we have the rooms enough for their accommodation, but challenge is the classrooms. We do not have any item for skills lab. So the situation now is not the best, but at least it has kept us going. This school is not helping me alone. It is helping the communities of South Sudan, and it is improving the health of South Sudan in general. The outcome of the students that we have trained have motivated me so much.
So as a midwife, your role is to take care of a woman since from the day she got pregnant until the day she delivered, and 6 weeks after delivery. You make sure that you give her the necessary care you can able to give her and save her in case if there's complication. If I'm the one who conducted delivery, my baby is saved and the mother is saved, I myself even will be more happier than the woman who gave birth. Because I've saved life and I've welcomed what? Life into the world. Esatto, adoption itu.
Currently, we are having 3 classes of diploma midwives training. Students come from all over the country. So it's a national training school. My students are united. They feel they are one.
I would like to see peace, and I would love to see if our women are really staying in a peaceful environment and they can able to educate their children without any interruption. So that's what we are hoping for.
I believe only one time the communities will come back, then these trained people will go and work on the communities. The more midwives we have, the more opportunities we give to our pregnant mothers, and the more life we give to our babies.
This is a place with so little, by so many measures, with a future so precarious and paradoxically so wide open. They don't have peace yet. But they do have grace.
So, again, 3 very powerful movies with very powerful messages that we'll have the opportunity to talk about here together. What we'll be doing for the remaining time is we'll start off with a dialogue with ourselves here and with our 2 guest members who are joining us online. You'll see them show up briefly or very soon on the screen there. And for the last couple of minutes, we would really love to open up the floor to all of you. So already maybe you want to be thinking about some questions you'd like to ask us or any of the panelists, or maybe some open questions for other audience members. Great, I can see that our members online are also available for us to converse with. I'd like to start today with a question for Koiwah. So I know that when you were pregnant that there was not enough information available about eclampsia, and that led to some tragic loss of life. And I was wondering, what do you do and how do you organize and raise awareness in Ghana and in other parts of Africa, and how do you use film to do so?
Well, thank you, Megan, for that question. Rightly so, I'm a 4-time survivor of hypertensive disorders of pregnancy. Out of 4 pregnancies, I've lost 3 babies. I have 1 surviving child who was just 10 years old. And the other 3, 1 was a stillborn, and 2 came out prematurely and died 5 to 7 days after. Ignorance killed my first baby. I had no idea. Attended all the antenatal clinics, private hospital. The doctor saw me, the nurses saw me, but nobody mentioned or said anything about preeclampsia. And so my first experience was full-blown eclampsia, not even pre. And after having that and a repetition of it in 2017, I decided to ask questions and find answers. And that was when I yearned for a group or a survivor, somebody who could relate to my story, besides the academician or the doctor. And I realized that there was no such group in Ghana. So I ended up getting help beyond the shores of Ghana, virtually. And so then, because of this, and the fact that my mom had had preeclampsia, but up until the time I was being rushed to the hospital with my first pregnancy, and we called her, and all she could say was, "Oh, that's my disease. We never knew she had it." But could you blame her? Maybe she didn't know it could pass on to me. And so it was out of this second experience that I decided to find an NGO, a patient advocacy organization, namely Action on Preeclampsia Ghana, to provide education to women out there, both in the rural and urban. I mean, hey, I was an educated person, always online, social media, talking to people, but I still was ignorant. And so that is what we do, where we go into the communities, educating people on the ground, educating their families and partners, and also taking advantage of the virtual platform. We also tend to have a sort of education for the health practitioners, because you would ask the question, why were there all these symptoms, but nobody said anything? What is the issue with communication with our health practitioners and us, the patients? Why is it so hard for them to communicate the risk and the diagnosis, therefore? And so we do that as well by providing capacity building programs for these health practitioners as well. So that is the many ways. And in doing that, we partner with traditional leaders, we partner with the media, we partner with the regulatory system there. In Ghana, we have Ghana Health Service. And then we partner with every relevant stakeholder, because it's a community affair, it's a community agenda. And to be able to save lives, we have to do it together.
Yeah, it's beautiful. Beautiful that you're taking a holistic approach to it. And I think we'll return to that in a couple of minutes. And thank you, of course, for sharing what you've gone through. That leads me to a question that I have for Doris. What is the WHO doing to increase awareness and improve health for women at risk of having preeclampsia or eclampsia?
Thanks, Megan, for the question. And thanks, Koiwah, for sharing your experiences, which unfortunately, we know that they are not necessarily uncommon, as you say. And I think you picked up on a couple of things that are really important. And that is, first and foremost, that it is possible to detect preeclampsia. It's possible to start preventative measures if a woman is identified as being high risk. And it's possible to treat a woman who has preeclampsia to avoid eclampsia and to avoid some of the outcomes that you've mentioned, most notably losing a baby, either through stillbirth or prematurity. The idea is to get a woman who is at risk for preeclampsia and or eclampsia through her pregnancy, and so that you have, at the end of the day, a healthy mom, a healthy baby, and a healthy family, as we saw in that video. WHO is working on several fronts. You know us as the normative agency, meaning the agency that provides guidance and guidelines on what to do and how to do it. So if you're the healthcare worker, you are meant to know certain things. And Koiwah, to your point about the issue of why healthcare practitioners don't speak about this or give talk about the risks, these are things that we're working on, as to how to improve that communication, but how to also make sure that the healthcare provider feels that they know what to do and that they have the ability to provide those medications, and that they're safe to give. I can tell you from experience, having practiced obstetrics, that there are lots of physicians who don't feel that they can give a medication in pregnancy. And specifically for prevention of preeclampsia, you know that one of the medications is aspirin. We have a lot of education to give to healthcare professionals on the appropriate use of something like aspirin for prevention of preeclampsia. So that's just one example. I want to just touch on a couple things because I know that time is short. But WHO is also working on research to improve access to medications for treatment of preeclampsia, such as magnesium. One of the biggest roadblocks is how nurses and midwives and physicians can give magnesium sulfate, which is a treatment to prevent eclampsia when a woman has been diagnosed with preeclampsia. And the other thing is working on the front of policy and informing innovations with developing what we call targeted product profiles, which basically say to the world, if you want to be in the space of working to prevent, treat, or help in the space of preeclampsia, these are the things that we need you to develop. If you're going to come into this space, here, make sure that it's safe in pregnancy. I mean, these are common sense points sometimes, but we need to put them down on a piece of paper that says, if you're going to work in this space, this is what we're expecting of you as a manufacturer, as an innovator, as a researcher. These are the questions that we want you to work on. And the final thing I want to say before I pass it back over to Megan is quality. Quality of medications, quality of healthcare, quality of the experience. We will get nowhere if the medications that we're using are of poor quality. We'll get nowhere if the care that is being provided is of low quality. And as Koiwah said, it is about partnership. I can tell you that listening to the last video about how the midwife felt that she was the happiest, it is because it is that partnership. Everybody's part of this team. And so at the end of the day, WHO is working very hard to make sure that everybody in that team atmosphere knows their role and their responsibility and what they can do to make a change so that experiences are positive and that we don't have the things that happened to Koiwah and to the woman in the video on preeclampsia happen before somebody says they have to do something. We have the means and the ways to make it right the first time around. Thanks so much.
Thank you, Doris. Just a wonderful and informative little talk there, and I think that we'll touch on some of those points again in the upcoming minutes, but what I hear already as a sort of pattern emerging is this idea that it's a collaborative effort, that, you know, on one hand we could say, why did this person do something or not do something, but it's also something that we can look at together as a team of researchers or lived experience experts or policymakers, so thank you. I want to take a small pivot to the first film that we watched, and that was Efun. And Gilles, I actually would like you to share with us some information that I wasn't aware of when I watched the movie for the first time, and I only learned when we were talking about it. And that's about Anita Abada, that's the director. Her choice in choosing a fictional story instead of actually a documentary style like the other two movies. So can you tell us why she chose to use actors and a fictional plot or a scripted film, and what she did with the film afterwards?
Yes, yeah, that's a very important point for us in the film festival is indeed to highlight how the film can be used for health education, health promotion. And Anita Abada, to take your second point, she has made this film and used it in Nigeria to educate the community leaders. She used the film in different locations. And she invited the community leaders in the school, where she could also invite the teachers and the girls, and showing the films to this group, and then making sure that the dialogue would be installed and that this right to say no to FGM for girls and for mothers to support them in that would be understood by community leaders. So she did a great job in Nigeria, and I would be interested later that you would tell us in Ghana whether this kind of thing could happen, as you do also the similar things with about preeclampsia. And so we have, if you want to learn more from Anita Abada on this, you go to the webpage I mentioned at the beginning during the intro, Health Impact Through Film. you go to the educational tools, and you will see one we made where Anita Abada was herself interviewed and giving a testimony about this action she has done. Now, and also, by the way, there's a panel discussion in this same webpage where Koiwah was invited last year about preeclampsia. So you have another tool, another panel discussion on preeclampsia in this webpage. Now, why she made a fiction, maybe Koiwah would reply better than me. My assumption, knowing, since I have filmed a lot in African countries, and I had the chance to cover that topic a few times, my assumption is that it could be very difficult for a documentary approach to be made with real girls, I would say real in terms, not fiction characters, I mean, because this girl is real, but she's acting. But for her to say the same, or to do the same in front of camera, and not as an actor, but as a young teenager in a village, I suppose it's going to be very difficult for a filmmaker to record that, because I remember so it's a bit long ago, but I'm not sure it has changed a lot. In some remote areas in Mali, in Niger, I remember, for instance, for interviewing some young girls, I had to use a stratagem, okay, a strategy with social scientists being with me, and the social scientist would pretend he needs to interview the father, so he was taking the father away from me, and then I could interview the young woman and making sure that no old woman would be around and listen, because the young woman told me, I cannot speak in front of an old woman because I am a young and she's elder. And secondly, of course, the old woman would not speak in front of the men. So, publicly, I mean. Of course, in the family, it's different. So the only way for girls to speak together, according to this interview, was for them to meet at the water point, only the young ones, and then they could speak freely between themselves. So I don't know if it's still a situation like that in Africa, in some villages, still the case. It was a bit, maybe 10 or 15 years ago, I recorded that. Anyway.
Yeah, so being creative, not only as a filmmaker and trying to get the voices and the narratives that you need, but also keeping in mind the context, the site-specific context and rules and norms and practices. I don't know if you want to speak briefly to that in your own experience as a filmmaker.
Just to add to it, there's a saying that says that if content is king, context is God. And film is really one of the powerful ways of advocating and telling a story, because the truth is, where I come from, we like reading, but we also don't like reading. And so one of the greatest ways to get people's attention is through story and through films of this sort. So even as an NGO ourselves, we produced a short documentary called Preeclampsia Diaries, where you had women coming out. And the fact is, a lot of women are ready to voice out, but they're only ready to voice out with a hidden face.
Yeah.
You only find a few who will really want to show their face to be part of such films and to project it. And so then I do understand why, the producer of that film did use fiction, because most of these matters are sensitive. You are also looking at culture. We are a highly patriarchal society. And so you can be voicing your story and your husband will know it's your voice because your face will not be showing, but at least you would have voiced out.
Yeah.
So yeah, that's just the experience we have.
Yeah, thank you. I want to link that to Christina. Christina, I have a question for you that's related to this. So how are you using experience narratives, like you just mentioned, the voices of women, in your own approach to encouraging people to stop FGM and to combine that with evidence-based practices? How does the WHO or your research team approach this?
Yeah, thank you so much for the question, Megan. This is really an important part of the work that we've been doing. In fact, we realized that We know that there are 200 million women and girls who have already undergone FGM. So of course we need to make sure that healthcare systems are prepared to provide the treatment and care for the complications. But at the same time, there's such an important role for the health sector to play in prevention as well. And we've really focused our efforts at the primary care level in high prevalence settings. And so most of the health workers at primary care level are the health workers like Grace, who we saw in the film, who are midwives, who are nurses, and who are really part of the communities, but also able to reach the communities in a way that's unique because they understand the social norms that are driving the practice. They themselves might have undergone the practice. And in fact, we also know that some healthcare providers themselves are performing FGM. So it's not just happening by kind of traditional practitioners, but sometimes health workers themselves are doing that. So this is really for us a really important area to reach. So realizing this and realizing that there weren't tools already existing to do this, we did a lot of listening and learning and really talked a lot to community members. We talked to health workers themselves and those working within the health system and professional associations, and particularly with midwives, and realized that there is research from other areas as well, that midwives are extremely influential and they can influence their peers, they can influence those that they're teaching, as well as their clients and their patients and the family members and community members that they're surrounded by. So we listened to a lot of these stories as we developed our materials. And what we also did was we developed an entire training package that's aimed at nurses and midwives. And the first step in that is for them to come together and really start to discuss the values and beliefs and attitudes that they themselves hold as a first step in trying to build them as communicators for change and to build their role as opinion leaders in their community to end FGM. So that's a really important step, and a lot of that really works with listening to personal experiences and building on that. And we use that as part of this training. We also developed a video, this animated video, and I would be happy to share the link because I think everyone who sees it finds it really powerful as well. And it's a story of a midwife also who comes to realize that she can play this important role. And she's always wanted to do something about ending FGM, but she herself didn't know how. But then she realizes this whole approach that we've developed is quite powerful, and she starts using that and communicating with all the different people around her in all the different roles that she plays. So we tested this approach, and we did so by having the midwives and nurses undergo this training. And then they spoke to women on an individual basis during the routine care that they were providing. And they used that opportunity to discuss, where the women were in their beliefs and trying to work with them about changing their beliefs. And we did this in a person-centered way, a woman-centered way. And we had really positive results. We actually tested it in a randomized control trial approach in Guinea, Kenya, and Somalia. And these results are really the basis now for us to scale this up. And I mean, we're quite excited about this because this is really an untapped sort of resource of the midwives and nurses and those working at primary care level. And really behind all that are the stories and really trying to build on those and to recognize the individuality of it, and that women have reasons that they put their daughters through FGM. And as we saw, like the mother in the film, her intention isn't to hurt the daughter, she thinks this is the right thing to do. So it's really important to recognize that, even though it is a harmful practice and we are 100% committed to ending the practice, there's a lot of reasons behind that, and there's a lot of social norms behind that. And unless we address those, even within the health sector and with our partners, as everyone else has mentioned, it really is a partnership also with other sectors. But this is really critical in these efforts, and also happens to be effective as well. So this is a big part of what we're doing to try to make our contribution as a health sector to end FGM. Thanks.
Thank you. And it sounds like you're using a variety of approaches. You're being creative, not only in the materials that you develop and use. And if I hear it right, just kind of playing the long game. It's not something that changes overnight, and it requires open dialogue and an approach that's, again, catered to the specific sites and cultures that you're trying to reach. Thank you for that. I think we have time for one question from the room here. Bente is available. Bente has a microphone in the shape of a spongy box. So if there's anybody who'd like to ask a question to one of our panelists, now's your moment.
No question.
All right.
Hi, my name's Julia, and I'm from the University Medical Center Utrecht. I was just wondering about the first film. It seemed like it was very focused on empowering and seeing the woman's perspective, but I was wondering why there wasn't also a focus on an integration of men's involvement in the kind of empowerment of men to also speak up against FGM, and what the kind of decision-making process was, or what we might be missing out on by not including that perspective.
Whose perspective? There's the microphone.
Men.
The men's perspective.
The men's perspective.
Yeah.
So the fathers, the community leaders,
Yeah.
other kinds of perspectives, because it seems like it put a bit of pressure on only women to speak up.
Can I answer?
That's a really interesting point, and it's also, I assume, a choice of the director to focalize through the mother and the daughter, but it is noticeable that that's a lot of women. I wonder, Christina, if that relates in any way to the work that you've been doing and how you target your information that you're sharing, or your interventions.
Yeah, thank you for the question. I can't speak for the director about her choice, but I would say that generally in most of these societies where FGM is practiced, that it is often the choice of the mothers and the grandmothers and the female family members. So I think that's was probably a deliberate choice, because often they are making those choices. This isn't to say that we shouldn't involve men. Of course, we need to involve men in these efforts as well. In fact, in many of the countries, there is data on this too, that in many settings, more men are opposed to FGM than women. And in other settings, it's the other way around. But in any case, we need to, if this is a social norm, and we need to change at an individual level and at a societal level, we really need to engage all of the actors. And often women report that they're doing the FGM on their daughters, or having it done to them because it makes them more marriageable, or because they will fit in better in society. And often they think that this is what men in the society will prefer. And we do know that from research that that's not necessarily true, but there are a lot of really impactful efforts that are happening on the ground that are engaging men. And I think this is absolutely a critical element of the work that needs to happen in partnership and in conjunction with all of the other efforts that are happening across the other sectors and with all the other actors.
Thank you. Yeah, I think there's a lot of a great body of information that your research group is producing. You can look on PubMed, but also on the websites, and then see all of the wonderful work.
I just wanted to add that in Ghana, there's a Ghanaian scholar by Dr. James Aggrey who says that if you educate a man, you educate an individual. If you educate a woman, you educate a nation. Yes, we need the men's voices, but the truth is most of the time, we are the ones with the children. And so when the woman has a voice, when she's educated, that is a ripple effect there. And so, yeah.
I think that is a wonderful way to close this panel session. Thank you so much for that closing thought, something to take with us. I'd like to, before we end this, give a special thanks to the technical support staff, all their wonderful work for making this go seamlessly. The organizers of the conference, especially Joyce Brown, Noah Kopla, and Gina Mellis for their help with these sessions. Benta, who's been helping us with the microphones. Thank you, Benta. And of course, Gilles, for selecting these films for us.
My pleasure.
We have one more day today, or tomorrow is the mental health session. Also, thanks again to our online members. Thank you for participating with us today, and thank you for your wonderful, wonderful comments. Yeah.
Thanks.